Okay, good morning, everyone. I am Christy Connor, the host of Friday Coffee Meetup. We are so happy to have you here with us this morning. Friday Coffee Meetup is the largest active innovation, entrepreneurial, and tech meetup in Los Angeles, California. We are traditionally an in-person meetup, but due to COVID, which we're going to be talking about today, we are actually broadcasting via Zoom and via LinkedIn Live. We also have a YouTube and a podcast channel. If you've ever missed some of our speakers, you can find out about them and listen to their amazing talks at those channels. Although you are seeing my face right now, we actually have a myriad volunteers that put this together each week, and we are so grateful for them, especially over the last year. It has been a challenging year for everyone. We did a pivot in March and April over to being virtual, and they have put in a ton of time and effort to be able to bring this whole event together and still serve our community. I wanted to show you their faces because although you are seeing mine, they are the ones that put in the blood, sweat, and tears to make this happen. And so this is our group of many people who helped get speakers and arrange logistics and help with networking and the website and the meetup page and the YouTube channel and the podcast channel, and just help create community here in Pasadena and across the world. One great thing about being virtual is that we've been able to reconnect with many of our members across the world who can now join us on a every Friday basis. So I want to thank them, especially all the volunteers who put this together each week, for their dedication over the last year through the challenges that we've faced. And as we go into the new year ahead, we're actually going to be taking a break until the new year, and we are going to be coming back in the new year with Nick Stein. So we're going to be excited to hear from him at that time. And we just want to thank as well all of our members for being with us through this adventure and still reaching out to your community members and being a support to them during this difficult time. With that, I am really excited to reintroduce Dr. Kimberly Shriner. Dr. Shriner had joined us back in April to talk about coronavirus and an update on the pathogen, and she is going to be doing that again with us this morning. She is an infectious disease and tropical medicine specialist from Huntington Hospital here in Pasadena, California. She has practiced with them for a while. She is also the director of the Phil Simon Institute, which serves underserved HIV patients, and that work actually extends into Northern Tanzania. With that, I am so excited and grateful that she has come back to join us again today. And with that, I'm going to turn it over to Dr. Shriner. Welcome, Dr. Shriner. Thank you for being with us again.
Thank you,
Chris.
You
can go ahead and, oh, sorry, go ahead.
No, just thank you very much for allowing me to come back.
Wonderful. We're excited. You can go ahead and share and start your presentation whenever you're ready. We will be seeing, we will be having a Q&A period at the end. So please go ahead.
Well, thank you very much for asking me to come back and kind of give an update. And I would say quite a bit has happened since when we last met in April. This has been a very interesting, if not trying time, and we're still very much in the depths of a very, very serious pandemic. So as we move into the winter months, we are also watching very carefully the convergence of another important pandemic virus, influenza. And so I thought I would sort of give you a brief overview of the COVID situation, but also in context with the coming flu season and what we can do to prepare for that. So, and you'll have to forgive me, the neighbors' gardeners here, so there could be some leaf blowing going on. Let's talk a little bit about the COVID situation. I think many people are certainly watching very carefully the really dreadful statistics and so forth that are coming from the East Coast right now, as we're really entering a very critical time with this pandemic. The unfortunate thing is that we are having a tremendous increase in the number of new cases, And that's built on a layer of pretty dense disease already, because the virus has now been circulating in the United States for at least 10 or 11 months. So that's a very concerning situation, especially in light of the fact that we really don't have very effective therapies, nor do we have a vaccine. So there's really a great deal of concern about where we're going with this. In addition, you built that on top of some of the economic issues, and I think the general pandemic fatigue, which is sort of the new mantra. People are really very unhappy and uncomfortable about where we're going as we move forward in the next couple of months. But I do think there are reasons to be optimistic as well, and I think I'll talk about those a little bit. So this was the dashboard from the Johns Hopkins site a couple weeks ago, but basically it reflects the same situation now. We're having an enormous amount of disease all over the world. There's no countries that have been spared, no continents that have been spared except for Antarctica. The United States and Europe have experienced dense amounts of disease, as have India, as has India and South America. Africa has had a lower incidence of COVID. Whether that's a reflection of a true or lower incidence, perhaps some underlying immunity in some of their populations, or most likely underreporting, we don't know for sure. But suffice it to say that it is very much present on the continent of Africa, especially in South Africa, where they have very good reporting. And so I think this is a disease that we're going to be dealing with for quite a while. Currently, as of yesterday, we had 47 million cases confirmed around the world, with unfortunately 1.2 million deaths. Those numbers are going to continue to rise. And the United States has really had an enormous burden of disease. And we can conjecture as to how this has happened, but looking back, we're going to have to be very candid and take a very deep dive into why the pandemic has sort of been out of control in our country. But the bottom line is we're still trying to dig ourselves out here. We've got over almost 9.5 million confirmed cases now. 122,000 new cases were just reported yesterday, which is an all-time high and a very, very scary statistic. And more tragically, we have almost 250,000, close to 250,000 deaths now from COVID. That number will also continue to rise, and that is an important number that we have to try to control. Los Angeles County itself has had over 300,000 cases of COVID and approaching 7,100 deaths. So it is very well established in all communities, especially in the United States, and it is now in both rural and urban communities. And as I said, one of the concerns we have is that this surge that we're seeing is already built on a whole lot of disease that's existing here. So that makes these numbers even higher. And as it spreads into communities where nobody has any immunity, because nobody has any immunity to this pathogen, except for those individuals who have been infected, and when it passes into new communities that are sort of virgin territory, it really does kind of wreak havoc. Now, the demographics of some of these people of the people now that are coming down with coronavirus is a little bit different than it was at the beginning of the pandemic. As you may recall, back here in April and May, we had an enormous amount of nursing home catastrophes with very high mortalities because of the population that it affected. Now we're seeing it spread throughout the general population. So we're having young people, older people, healthy people, unhealthy people, and many of the very elderly at least have been somewhat protected a little bit because we've recognized that they're a very vulnerable population, and nursing homes have closed down to visitors and they're screening their staff that are working there. So that population has been a little bit more protected, but we still see outbreaks in nursing homes and assisted livings and so forth continuing. So very, very high density of disease. And this is not the kind of curve that you want to see. This is really a pretty scary thing as we're moving into the winter. We're having a tremendous amount of disease on the East Coast, especially in the Midwest. Wisconsin has now, their hospitals are using their surge tents, which is really the final end result of a pandemic that's out of control, is when the hospitals become overwhelmed and they're not capable of taking care of not only just COVID patients, but also everybody else who has heart attacks or a gallbladder problem or cancer or whatever. There's a lot of collateral damage that is occurring and that we've recognized is occurring because of this pandemic, outside of people that are affected directly by the virus. And we certainly see that even at Huntington, where we've been very concerned about the postponement of not even really elective surgeries that need to be done, people that have cancers that need to be taken care of, or people that need to have heart valves or pacemakers. A lot of those, as the hospitals are overwhelmed in dealing with COVID cases, those have to be put on hold. And so one of the things that we're doing at Huntington, and many hospitals around the country are also trying to do, is to learn to sort of how do you cope with coronavirus, but also try to run your hospital and do it in parallel. And it's a very, very difficult task. I think it's almost an impossible task for hospitals that are in Midwest and Mountain West right now, because they're absolutely overwhelmed. They don't have enough ICU beds. They don't have enough staff. Remember that doctors and nurses have been doing this now for respiratory therapists, everybody who works at a hospital. They've been doing this now for almost 10 months, and they're pretty tired. And so there's a lot of fatigue in the staff. Some of the staff have become sick. And so it's really a very, very challenging time for our country and dealing with this pandemic, as it is around the world. We're not unique. Europe is having a terrible time. They, of course, are now on lockdown in England and in France and Germany, I believe, and Belgium has really gotten hit hard. So those countries have a little more control over their healthcare systems, because they tend to have centralized healthcare systems, but they are also getting overwhelmed. It's just a matter of numbers, and you can see that that's a very scary graph. So one of the things that we've been concerned about is, well, what happens when these two viruses converge? That's traditional for the flu season to begin now as people move indoors. The weather gets colder. This happens first back east, and then it happens in California a little bit later. California their flu season tends to peak in February or March, but whenever there's a cold snap and people move indoors, they can pass viruses back and forth. And both these viruses are very infectious, and so we're very worried about the two of them together. However, we do have a little bit of a preview of what might be a better flu season than we anticipated. This is a graph that shows what the flu season looked like just prior to the sort of emergence of COVID in the United States. And you can see that last year we were having a pretty bad flu season. There were a couple of nasty varieties that were circulating, these H3N2 variants that are very nasty, and influenza A type variants of the flu. And they have a pretty high mortality, actually, and morbidity. And so we were experiencing quite a bad flu season. Then when COVID happened, we shut down. We started practicing social distancing, and very early, lots of people weren't wearing masks, but gradually people began to wear more masks. And so you can see that the flu pandemic just sort of petered out. Now, it does kind of peter out anyway as we get into more warmer weather, when people go outside and they don't transmit the disease as much. But this was very dramatic. And what this showed is that both of these viruses are transmitted the same way, that they're respiratory viruses transmitted largely by droplets. I'll talk a little bit more about that with regard to COVID. But once people started socially distancing and there was shelter-in-place orders, then the flu season kind of finished. There was a short period of time, and we even experienced this at Huntington, where there were people that were co-infected, that they had both coronavirus and influenza. It's hard to know what the clinical consequences of that was, except that they didn't do very well. But I think we'll have to go back and look at some of that data in terms of whether there really was a significant bad interaction between the two viruses that really ramped up mortality. That data is not really known, but that was a short period when the two of them were very much together. But really, once COVID sort of took over, influenza disappeared simply because of the mitigation techniques that we were doing to try to control the coronavirus. And indeed, this also happened in the Southern Hemisphere. So influenza moves from the Southern Hemisphere to the Northern Hemisphere. And it does so, and it's a very important ability to look at the influenza pandemic or season in the Southern Hemisphere. That's how the vaccines are designed. So they look at what's circulating in Australia, New Zealand, and Southeast Asia, and India. And then the WHO comes up with a plan for creating the influenza vaccine for the following fall and winter in the Northern Hemisphere. Remember, the Southern Hemisphere, their fall and winter months or colder months are in the summer, our summer months. And what's very interesting is that you can see these are the influenza incidents in 2018 and 2019. And then towards basically once 2020 started the flu season, which in Australia starts sort of around May or June, it was just flat. There was hardly any influenza. And so what that tells us, again, because especially in Australia, New Zealand, and South Africa, they were doing very strong mitigation. There was really very little influenza circulating because they were trying to control the coronavirus through masking and social distancing and shelter in place and lockdowns, which is good news that maybe we won't have a bad flu season on top of a COVID season up here. But we do have to do the things that we know can control both of the viruses. So these are just some of the factors that were associated with probably a decreased influenza season in the Southern Hemisphere, and maybe some optimistic news for us as we move into the flu season in the Northern Hemisphere, that COVID pandemic lockdowns helped diminish transmission of influenza. There also was a decreased influenza testing. That is a factor you have to take into consideration as we were trying to develop tests for coronavirus. Children were at home. They weren't at school. We know when kids go to school, they circulate all kinds of viruses and they bring them home into their houses. And so that was certainly a factor. People using masks and social distancing. And then perhaps most importantly in terms of international and global movement of influenza, there's obviously been a huge decrease in international travel. And that also is certainly a very effective mechanism for influenza to move from the Southern Hemisphere to the Northern Hemisphere. So those are factors that probably resulted in a diminished flu season in the Southern Hemisphere, and hopefully that will carry over to us. That being said, looking at the 2018-2019 season, it was kind of a bad one. We had about 35 million cases in the United States, documented cases of influenza. 16.5 million of them required medical visits. There were about almost 500,000 hospitalizations due to influenza. Remember, this was before COVID arrived, or at least was circulating widely, and almost 35,000 deaths due to influenza. So influenza is a bad virus, and there's some differences in terms of how it behaves, and I'll talk about that, but it is something we want to pay attention to. So let's sort of look at the two side by side. Both of these viruses are transmitted by respiratory secretions. Influenza is a classic droplet-borne pathogen. In other words, it's transmitted by large mucus droplets when people speak or sneeze or cough or sing, and transmit the virus in fairly large droplets. And large droplets we're saying is probably greater than somewhere around 100 nanometers, which is about the size of sort of a tiny little droplet that you sneeze out your nose. What we are increasingly learning with SARS-CoV-2 is that it is a droplet-borne disease, but it is also easily aerosolized. What do we mean by aerosolization? Well, that means that in addition to the big droplets that are expelled when people sneeze or talk or breathe, there are little tiny micro droplets, and those get suspended in the air and they float around in the air. And because SARS-CoV-2 is such an infectious pathogen, much more infectious than influenza, those little droplets, they may have just tiny, tiny bits of virus in them, but that appears to be enough to infect people that might be farther away. In other words, somebody who's 10 or 15 feet away, who's in a closed space, and the ventilation system is not very good, that you can have what we call an aerosolization event, where people that are even more than 6 feet apart, where sort of larger droplets are not going to spread, may become infected. And that speaks to the infectiousness of this pathogen. And that's something that we really are recognizing increasingly as we begin to understand SARS-CoV-2. So influenza is moderately infectious. You know, you have the likelihood of somebody getting influenza if they have close contact with someone who has it is, you know, one to two people will become infected. SARS-CoV-2, it's somewhere in the line of, 2 to 3. So it's a much more infectious virus. It has become a much more infectious virus during the pandemic because of the emergence of what we call the 614 mutation, which is a mutation on the spike protein that has emerged, that emerged pretty quickly when the virus was spreading through Italy. And so most of the virus now in the United States is the 614G mutation that is much more infectious than the original Wuhan mutation that was circulating early during the pandemic. In influenza, people are usually the most infectious when they're symptomatic. So when they're feeling pretty cruddy, that's when they're most likely to have high levels of virus and be most infectious. We now know with SARS-CoV-2, another disturbing factor is that lots of people don't get very sick. They may not have any symptoms whatsoever, or have only mild symptoms, and yet they may be highly viremic and they can spread the virus very quickly. And as we understand more about the epidemiology of this virus, we also understand now that those are maybe one or two individuals in a room of 10 people, even a couple people who may have COVID, that those individuals may not be very infectious, but a couple people that are asymptomatic spreaders are highly infectious. So one person who is a very effective, highly viremic asymptomatic spreader can infect lots of people. And we've seen these super spreader events over and over again, both in the political world, obviously, but also in congregate living situations, or even the dreaded birthday parties or Father's Day events, where people get together with their families, who they assume it's my family, it's my parents, it's my siblings, it's my children. How could they possibly be infected? All it takes is one person with COVID who happens to be very viremic, might be asymptomatic, and the whole family comes down with it. The incubation period for influenza is about 1 to 4 days. SARS is a much longer incubation period, a median of about 5 days, but 2 to 14 days is fairly typical. That's why we use the 14-day marker sort of for quarantine. Symptoms are very, very similar. It's pretty hard to tell whether you have COVID or influenza on just the basis of symptoms. I will tell you that although fever is very common in influenza, it's common in SARS-CoV-2 and COVID-19, the disease caused by SARS-CoV-2, but it's not all that common. So using temperature as a screening technique, although it can pick up somebody who may have a low-grade temperature and not feel it, it isn't the best screening technique. So I don't take a great deal of comfort when airports use that as a criteria for whether or not somebody might have COVID. We do it at the hospital every day. And it's important to do that because you may pick up somebody who has a low-grade fever and they indeed have COVID, but it isn't a very good screening method. Headache and body aches, just like influenza, occur very commonly with SARS-CoV-2, as does a dry cough. It does have a couple peculiar symptoms. The first is this loss of taste and smell, which many patients describe. Some of them describe it at the very beginning of the illness. Some of them describe it sort of well into the illness. And then occasionally GI manifestations with diarrhea and so forth can also occur. The case fatality rate for influenza is about 0.1%, not insignificant. 35,000 people died of influenza last year. The case fatality rate for SARS-CoV-2 is much higher, 0.25 to 3%, as high as 10% in some groups, very elderly people, people with obesity, diabetes, hypertension, heart disease. Those folks have a much higher mortality with this disease. We have some pretty effective antivirals, especially they're called neuraminidase inhibitors. Oseltamivir or Tamiflu is pretty effective in controlling the symptoms and infectiousness of influenza. It can be used as a prophylactic drug in people who've had an exposure. It diminishes the days of infectivity. It doesn't necessarily, cure you that day, but it's very helpful. We really don't have very good medications for SARS-CoV-2. Remdesivir has been a disappointment. I use it in patients. It may shorten their hospitalization by a day or two, but it is certainly not a game changer when it comes to dealing with this virus. So we don't have very good effective therapies at this point. Obviously, we have very effective influenza vaccines, which I'll talk about in a bit. Unfortunately, we don't have any vaccines yet, and I will also talk about what might be coming. So here's the two pathogens side by side, and they both have sort of a concentric sphere-like appearance, and then they have various and sundry things scattered on the outside of their surfaces. For influenza, they have things called neuraminidase and hemagglutinin, which are virulence factors that allows influenza to attach to respiratory epithelium. This is how we type influenza. That's why it has H1N1 or H2N3. That's the certain types of neuraminidase and hemagglutinin subsets. SARS-CoV-2, the big player in this virus is the spike protein. Remember, this is a coronavirus. This is a beta coronavirus. Common colds are mostly alpha coronaviruses, which, lots of people have had common colds. This is an animal virus. It came from a zoonotic spillover. It's very clear that it came from the Chinese horseshoe bat. Whether it emerged in the Wuhan wet market or whether it was actually circulating in low levels in China before that, we don't know. But it underwent a mutation that allowed this virus to use this protein, the spike protein, to attach to human ACE2 receptor expressing cells, which are largely distributed throughout the respiratory epithelium, the nose, and the lungs and other areas, the heart, and even the gastrointestinal system. The spike protein is the name of the game for virulence of the virus. And it also is the main target now for a lot of the vaccines that are being developed. And I'll talk about that in a little bit. So we did touch on the transmission issue, but this is sort of a more graphic version. Again, as I mentioned, both of these pathogens are very least droplet-borne. SARS-CoV-2 appears to be much more likely to cause aerosolization. You can pass it from a contaminated surface to your mucous membranes if somebody sneezes or talks on the telephone loudly, and then you pick the phone up and you touch your mouth or your nose. Then that's potentially a source of inoculation, if you will. That's a much less common way of transmission. We know that most transmission is probably through respiratory droplets and often in close contact, usually at home. Household transmission is very, very common unless people are going to these super spreader events, which may be a birthday party or a rally or a protest or some sort of event where lots of people are gathered together in close contact and not wearing masks. We know that the amount of virus that you're exposed to and the amount of time that you're exposed to that virus are factors in terms of whether or not you can become infected. And so for healthcare workers, for example, when we're taking care of patients with COVID, although we are all wearing N95 masks, and in certain circumstances, we may be even wearing something called a PAPR, which is sort of the moon suit that you see doctors wearing. That's for procedures that are likely to lead to aerosolization. We want to try to limit the amount of time that healthcare workers spend in these rooms with patients because the longer you're in there, even wearing appropriate respiratory gear, there's a chance that you can become infected. And so that's why, again, people that go into places where they're going to be spending an hour or two, a restaurant, let's say, that's not very well ventilated, indoors, everybody's got their mask off because they're eating, they're talking, they're laughing. Those are very high risk events and can spread the virus very easily. Both viruses can be spread that way. So that is something that they have in common. This just shows sort of some types of respiratory events and how much of the large droplets and gas cloud, if you will, that are predominantly aerosols can be transmitted. Even just breathing, you can see that, that there's a fair bit of amount of circulating aerosolization. So that's why we sort of say 6 feet apart when you're just people are talking normally to each other, is that the most of the droplets are going to be down here. Now, if you're in a poorly ventilated closed area, 6 feet apart may not be enough because of this business where the droplets get suspended in the air. For influenza, that's not as much of a factor, but for SARS-CoV-2, that appears to be a pretty common way that the virus is spread. So there are risk factors that you have to understand for transmission for both of these pathogens. Obviously, you have to encounter somebody who's infected. And unfortunately, both of these viruses now are so common that it's very likely if you go to Trader Joe's on a morning to pick up your groceries, that somebody in that store may have COVID or influenza or possibly both. But certainly somebody may have COVID. You have to assume now the virus is so common in the community and we're seeing such high rates of percent positivity, in other words, number of people whose tests are positive out of people who've been tested, that it's very likely that during events where you're around a lot of people, somebody in there is going to have the virus. So you have to be in that situation to get the virus. Congregate living situations, whether they are nursing homes or assisted livings or dormitories at college or multi-generational homes where there's lots of people living in small quarters, especially when there's not good ventilation. Those are high transmission areas. And, you know, we certainly at the hospital seen entire families that have come down with COVID, some of whom have had 2 or 3 deaths in their families. So very, very problematic because of that's a normal human behavior, is to live together. We're not meant to be solitary creatures. Obviously crowds, whether it's a concert, not too many concerts these days, or a rally or a protest or something. Kind of interesting that during the protests that happened after the George Floyd incident, we didn't see too much disease. And that may be because most of those were outdoors and a lot of those people were wearing masks and they were moving. They were moving from one area to another. Some of the political rallies that have happened have been super spreader events because they were in one area. People were close together, unmasked largely in one area. Even outdoors, you can transmit the virus in those sort of circumstances. Again, the duration of exposure, the longer you're in those areas where there's virus circulating, and the inoculum size of the exposure. There's been, of course, very well documented events, choirs that have had choir practice where the entire choir comes down with COVID. It's happened in Washington State. There was also one, a very famous cases that were reported in Amsterdam, and quite a few deaths among the choir members. Singing really propels a lot of respiratory droplets, and so those are high exposure events. The host also has risks for acquisition of the disease and or a poor outcome. Obviously, the age of the host. It was originally thought that children didn't seem to get very sick, nor did they get the disease, but that's proven not to be the case, that kids actually do get the disease and actually can have quite a bit of illness with them, and unfortunately some deaths. Usually it's children between the ages of 5 and 18 that are more likely to acquire the disease and become sort of super spreaders, if you will. Little kids don't seem to get it as much, little tiny kids, but they can, and they of course can spread it to other people. The very elderly are at high risk for bad outcomes if they acquire COVID and influenza. That's true for both viruses. Obviously, occupational exposure, healthcare workers, first responders, essential workers, bus drivers, grocery clerks, very high incidence of COVID in those occupations. So that is certainly something we have to consider for vaccine protocols. And indeed, healthcare workers and essential workers are going to be probably the first groups that are vaccinated. Unfortunately, both of these diseases move very quickly and cause a lot of problems in lower socioeconomic communities. And there's a disproportionate number of people of color that acquire both COVID and influenza and have bad outcomes. And so this really is a factor of maybe not good access to healthcare, multi-generational homes, having to work. You can't stay home. You can't shelter in place at home. You have to work to feed your family. All of those factors are very important, and it's not uncommon for these kind of pandemics to really sort of peel off the very thin veneer that we have over our society in protecting people in lower socioeconomic and vulnerable populations. And then obviously individuals that have other kinds of diseases like diabetes, obesity in particular, very important comorbidity that seems to have a bad outcome if you get COVID. Fat cells express a lot of ACE2 receptors, and that may be why they do less well. Again, I just wanted to bring home the fact that most transmission of SARS-CoV-2 often comes from asymptomatic carriers, people who don't know they're infected. And it's always, there's just always the terrible, sad stories of the kid coming home from college and goes to the Father's Day event, and somebody there gets COVID and has a bad outcome. Elderly people that are at parties and so forth, very, very high risk of acquisition of disease if somebody's there with COVID. So how do we reduce transmission of these two pathogens? Well, obviously, as we move forward here, the one very, very effective way for controlling both of these pathogens is wear a mask. It's a simple, easy, safe, cheap way of controlling all kinds of respiratory illnesses. And why it's become politicized and become such a point of contention in the world, frankly, not just in this country, but in other countries, is baffling. Plus, it can be a fashion statement. You can express your opinions about things on a mask, but it really is a very easy way to control this pandemic. If you masked everybody on the planet for 2 or 3 weeks, this virus would probably disappear. And the good news is it doesn't even have to be an N95 mask. You can see that N95s are very effective at preventing large droplets and even smaller droplets down to 0.1 micron. And they work a couple ways. One is that they're very tight catching areas, but they also have some electrostatic properties in an N95 that captures the little tiny micromolecules. So this is the mask that most of us wear when we're taking care of patients. All of us should be wearing at the hospital when we're taking care of patients with COVID. But even surgical masks and even cloth masks make a difference in terms of controlling the amount of virus that you can spill out to somebody else and protecting you from somebody else contaminating you. So data after data after data show that masks work. They're highly effective, they're cheap, they're easy, and they're a super important part of getting this thing under control. The other way, of course, we're hoping to get COVID under control, but we certainly can control influenza, is vaccination. This is the 2020-21 vaccine. You can see it's got all these different kind of symbols and numbers. This is a reflection of what the WHO does to try to make sure the vaccine contains all of these components, because these are the most likely variants of influenza that will be circulating this year. They don't always hit the mark. Sometimes they goof up. And sometimes you have the emergence of a new pathogen. That happened in 2009 when H1N1 appeared on the scene. That was a little bit of a pandemic at that time. And so now all influenza vaccines contain an H1N1 moiety to make sure that you're covered for that. But it is it's what's called a quadrivalent vaccine. It has both 2 types of A and 2 types of B. And these are the ones that are being used now. All the vaccines have basically the same kind of composition. And so they all are very effective. These are the different vaccines. They're made by many different companies. There are what we call trivalent vaccines that have 2 A's and 1 B. Most of the time we recommend quadrivalent, but there's probably not too much difference. Just a flu shot will protect you from influenza. Doesn't really matter what it has to be. If you have an egg allergy, there's a recombinant flu vaccine called Flublok. So that can be used in people who have an allergy to eggs. You can't get influenza from the flu vaccine. The flu vaccines, with the exception of one, are all killed vaccines. There's only one live vaccine that's used mostly in children. We don't use it very much. And that you can potentially shed virus but you don't get sick with it. But you could infect somebody else who's not vaccinated. So we don't really recommend that vaccine too often. It's a nasal injection rather than a shot. But all the other ones are killed vaccines. You can't get the flu from the flu shot. Why do people say they get that? Because when do we give the flu vaccine? We give the flu vaccine in the wintertime, and that's when coronaviruses, the plain old alpha coronaviruses and other respiratory viruses circulate. So the day you go down to get your flu shot, you go down to the pharmacy and you get exposed to some other respiratory pathogen and you get that and you think that's the flu. Can you get other bad things from flu vaccines? The data really show that they are very, very, very safe. Most of the components that they add to flu vaccines are very safe. There's no mercury in these vaccines that would harm you. There was a drug called thimerosal, which is used sometimes as an adjuvant agent that was similar to mercury. That's not used in most of the vaccines. Now they're very safe. People don't have terrible calamities from the flu vaccine. Once in a blue moon, you encounter somebody who does have an allergic reaction, perhaps to some part of it. And in those people, you probably shouldn't vaccinate them with that type of vaccine. This is maybe a good alternative, is to use a recombinant vaccine for them. But we know that the flu vaccine saves lives much more than it harms people. It really doesn't harm people much at all. So everybody should get a flu shot. If you're 6 months of age or older, you should get a flu shot. We recommend that you get the flu vaccine usually at the end of October. If you get it a little bit too early in our season, if you get it in August, it may wane a little bit in terms of its immunogenicity by the time we have most of our flu circulating. So end of October is fine, but you can continue to give it through the season. If you haven't gotten your flu shot yet, go get your flu shot. You can get it all the way into January and it can protect you. Again, we kind of recommend the high dose quadrivalent for people that are older than 65. This is a much more potent flu vaccine. It's 10 times the amount in a regular vaccine. So if you're 65 or older, that might be the vaccine that would be of some benefit. There's been some data that have shown that that's more immunogenic in older people as their immune systems get a little bit less robust. But any flu shot will do in a storm here. So, and you can give this live attenuated intranasal spray for people that are not immunocompromised, but I don't recommend it too much because you never know when you're going to encounter somebody who's immunocompromised. So let's talk a little bit about how to prevent transmission of SARS-CoV-2. The 6 feet mark, as I mentioned, is kind of the distance that large droplets can be spread. And so that's why we say keep 6 feet apart. But in certain circumstances, it might need to be farther. Again, if you're in a choir or you're in a gym and you're running and breathing hard, maybe 6 feet may not be enough. Those are all sort of high-risk behaviors for viral transmission, but that's sort of where that data comes from. There's no question that masks work. They really make a huge difference in terms of your ability to transmit the disease and to protect you from other people who could transmit it to you. Again, I'll show you a little bit of data on the different kinds of masks. Washing your hands is a very effective way of diminishing the amount of virus that you could inoculate yourself with. The gloves thing, I see people going to the grocery store wearing gloves. And the problem with that is that if you touch a contaminated surface with the glove, and then you touch your face, you're doing the same thing as if you just had your skin. So it's not terribly effective. If it makes you feel better, it's okay, but just remember you still can't touch your face after you've touched potentially contaminated surfaces. And then gowns and peppers are things that we use in the hospital when we're taking care of patients with COVID. So this was a study that came out fairly early in science that again showed the effectiveness of masks. People that are wearing the mask are protected themselves, and the amount of exchange of potential contaminated respiratory droplets just diminishes if everybody's wearing a mask. It says a lot about you that you care about the person you're with or the people that you're with or your community if you're wearing the mask. You got to wear the mask over the nose. You can't have it dangling below your nose or under your chin. It has to be over the nose to cover the respiratory areas to protect you and to prevent you from transmitting it to other people. And there are lots and lots of studies now that have shown that in communities that have mandated mask orders or when people are more compliant with wearing masks, that there's an enormous drop in disease and it saves lives, up to hundreds of thousands of lives if masks are used universally. So they really are a very inexpensive, safe, and helpful way of protecting people. This was a study that was published in Science Advances that looked at different types of masks. And you can see that even just plain old cotton masks work pretty well. These are N95s. They are the best. They're sort of the gold standard. But surgical masks work pretty well. Different types of material, polypropylene, cotton works pretty well. The bandanas, not so much. Bandanas have an area underneath where there's can be virus getting in. There's been some thought that bandanas may actually cleave the size of the particles into smaller particles. They don't have this electrostatic effect that some of the N95s have. And so they might actually be more effective for spreading the virus. And of course, fleece masks don't work very well at all either. And no mask doesn't work at all. So the valved N95s, you see a lot of people walking around with those. Those protect you, but they don't protect other people from you. So I don't recommend those very much. They're nicer because your glasses don't fog up, but they're probably not quite as protective. And if the valve isn't working properly, it's entirely possible that you can actually inhale infected material through that opening. We talked about good hand hygiene. Doctors are some of the worst in washing hands. We've always struggled to get physicians to wash the hands. We have about a 98% hand washing rate now at Huntington Hospital, which is good news. We're seeing a large decrease in other kinds of infectious diseases. The dreaded and scary primetime Amazon man. I think that this is an uncommon way of transmission, but it can occur. This was a study that was done early in New England Journal that looked at the retention of infected material on different types of surfaces. Again, telephones, computer keyboards, high touch areas, those are potential places for transmission. A package that sits out on your patio that's been delivered by a delivery person, even if they had COVID, not so much. Most of the delivery people, Amazon, Prime, all those places, are FedEx, their workers are masked. Many of them are gloved. And so the likelihood of transmission is small. I don't do my old sanitization of the package thing anymore. I do open the box usually outside and then take the contents out, but I don't worry about this too much. It could happen. It's not very common. This is a really important one for those of you that work in places where there's lots of people working, is really encourage your coworkers not to come home or not to come to work if they're sick. There's a big tradition in American culture that, you've got to be a workaholic, you got to put in your 20 hours, you've got to drag yourself to work when you're feeling terrible. This happens a lot in medicine. Doctors will notoriously make rounds when they're feeling really sick. It's just dangerous to do that now. And it's really, you're endangering people's lives if you happen to have COVID and you drag yourself to work. So if you feel sick, stay home. This is not the time to be, to put in the long hours. We know that outdoors is much safer than indoors. This was pretty clear very early on. And that was recognized even during the 1918 pandemic. This is New York City with the school outdoors. None of these kids are wearing masks and they're probably freezing their tails off, but at least they're protected out in the open. A lot of colleges, including Occidental, where I'm doing some consulting, are planning on these kind of venues for when they bring students back on campus. It's a little harder in terms of sound and so forth, but it is a much safer way of having people gather together. I'm not going to spend too much time on the pathophysiology. This just shows COVID and the kind of emergence of antibodies. Your own immune system responds to the infection. Again, people are most asymptomatic for the first 5 days or so after exposure. Then they may have onset of symptoms, and that's when they begin to have their symptomatology begins to wane. Now, 80% of people who get COVID recover. They don't seem to have They may not have long-term sequelae that we know of, excuse me, at this point. But then about 20%, 15 to 20% of people will have more significant disease. Maybe it doesn't warrant being hospitalized. About 5 to 10% of people, however, may have really terrible disease. And those are, of course, the people that I see. And it is impressive how awful this virus can be. It can affect many different organ systems. We know it certainly affects the lungs. It likes to go where there's the expression of ACE2 receptors, and that's pretty much throughout the body. We are seeing some unusual manifestations, things like cardiovascular issues where they can have heart muscle problems. We certainly see this embolic event where people's coagulation systems kind of go haywire and they throw little clots, so stroke and different kinds of vascular events are common. We know that it can affect the brain and produce seizures and encephalitis. The liver and the kidneys may be affected by this virus. So it really is a universally bad thing to get. And it has very, very devastating effects on the body. How does it do it? It causes chaos in the inflammatory response. You know, you have this great immune system that is supposed to activate when you get a virus. But what happens with COVID is that SARS-CoV-2 is able to go in and just kind of turn it on and then just create chaos where it overreacts and becomes very dysregulated and out of control. And you get this just immense number of immune activation that causes a release of inflammatory chemicals, disruption of normal inflammatory responses, and then eventually leads to all kinds of sequelae like clots and fibrosis and so forth. And so it can be very, very, very bad. We talked a little bit about the risk factors. There is some evidence that certain types of blood types may do less well than others. Type A may be more higher risk factor than perhaps type O. That data looks a little bit murky and we still don't understand it, but there's no question that having other underlying things, especially this one, obesity, which is a global problem, that one seems to really be a big risk factor for a bad outcome. This is the end result. This is a very typical CT scan in people with COVID, where they get these kind of peripheral manifestations of pneumonia. The lungs become very fibrotic. This is a lung that was removed from a 29-year-old. She actually had a bilateral lung transplant because that's what her lung looked like after she had very bad COVID disease. A young person, not supposed to get that sick. Young people do get sick and can have very bad outcomes. And you can just see it's hard to imagine how anyone could oxygenate with this as their lung. So how do we make the diagnosis? This has always been a conundrum in terms of where we can go with identifying people with disease. Very early on, we didn't have enough tests. Now we do. We are beginning to get better at it. The tests are still few and far between, but we are having better tests that have a much more sensitive and good specificity. They're faster. And many of the hospital areas have nasopharyngeal swabs that can test for influenza and SARS-CoV-2 at the same time. So you can do a nasal swab and get both answers. The saliva tests are beginning to be developed. They look very promising. They're inexpensive. They don't require PPE for the person who's collecting the sample. They don't go way down into your colon to get the test. Their accuracy is still a little bit iffy. Antigen antibody tests are very fast, but they have poor performance. They produce a lot of false negatives and can get you into some trouble if you don't know how to interpret them. I'm not going to spend too much time on therapies for COVID. We certainly, as I mentioned, have decent therapy for influenza. Not perfect, but decent therapy. For COVID, really not much. And I'm sorry to say that after 10 months, we still don't have very good therapy. We know how to manage these patients a little bit better. We try to delay ventilation, putting them on ventilators. We give them supplemental oxygen. Remdesivir has been kind of like I said, not a great success. The use of anti-inflammatory drugs is controversial. The only one that seems to be of some benefit is dexamethasone, but when you use it is still unclear. The only study that's been done was called the recovery trial, and that was in patients that were very critically ill. We do use it in many patients now. Convalescent plasma has been kind of a disappointment. We still use it. I use it sometimes. It doesn't hurt people, but it probably doesn't help. Monoclonal antibodies, this is the Regeneron product. Although you can certainly see that the president who received it sort of danced out the door. It's still in trial. We don't know whether it works. Eli Lilly was developing a recombinant antibody therapy that they took off the market because it didn't work. So the Regeneron product is still very much unclear about whether it works or not. we do.
Dr. Shriner, I know we have to wrap up with you at 8:30. Are we getting to a place we can take a few questions before we wrap up?
Yeah, let me just, I got 2 seconds. I'm actually okay because I
Sure.
can go a little bit till 9:40 if we have to, but
Okay, wonderful.
so I'll just kind of speed up here a little bit. The issue of whether people have long-term sequelae with this, we are seeing these kind of long hauler syndromes. So this is going to be something we're studying. We're actually looking at applying for a grant to look at long-term hauler issues in patients who have recovered from COVID. So I want to finish just with the vaccine issue because this is on everybody's mind. We know that vaccines work. These have been proven in animal trials that that animals that are infected with or that are given a DNA vaccine that protects them against SARS-CoV-2, it does work. How long those vaccines work has been a real problem. We have several different types of vaccines that are being developed. It's not important that we go into that right now. These are the big ones that are in trial right now. The Moderna vaccine is the one that Dr. Fauci is involved with. That's an mRNA vaccine. This is the AstraZeneca vaccine. That's a traditional killed adenovirus vaccine coming out of England. And then a couple other ones that are in different phases of development. 5 of them are in phase 3 development. That means they're in big trials now using 30, 40,000 people. We're probably going to begin to see some of that data emerge at the end of this month and into December. I'm hopeful that we're going to see some positive results. This is some preliminary data that came out of Moderna back in July. These were from phase 2 studies that showed that the vaccine did elicit appropriate neutralizing antibody levels, protective antibodies. We were concerned about how long that was going to last. This is the AstraZeneca data that showed the same thing. They also looked at cellular immune response, which is a very important part of the immune response in any kind of infectious disease. This paper came out last week. Very important paper. This was a huge study done in New York and 72,000 patients that had recovered from COVID. And why is this paper important? Because it showed that your immunity to SARS-CoV-2 lasted longer than 5 months, at least 5 months, perhaps longer. Why is that important? Because that tells us that probably if we can elicit that kind of immunity with the vaccine, then we're only going to have to give it maybe once a year instead of every 3 months. That's been one of the concerns, that immunity may disappear so quickly that it's not going to be protective by using a vaccine. So big paper, very important, very, very good news. I don't want to spend too much time on this idea of herd immunity. Herd immunity can be achieved safely with vaccination and mitigation techniques such as masking, social distancing, and locking down when you have to. To achieve herd immunity by just letting this thing rip would cost millions and millions and millions of lives. And infectious disease doctors and epidemiologists do not think that that would be a very careless and cruel technique for achieving herd immunity and is not very practical. Sweden tried that. They had a very bad outcome and their GDP actually dropped. So the argument that it would be better for the economy to do that is not a good one. Okay, so finally, the ultimate question, how can we have the holidays? I think the best way of looking at this is let's just have this one kind of skid through the holidays with minimal amounts of exposure to other people, really trying to practice social distancing and not having large gatherings. Celebrate in June when we have something to be thankful for, that we found an effective vaccine, that we finally got the pandemic under control. But in the meantime, what can you do to protect yourself? Get a flu shot. Wear a mask. Wear a mask when you go out with the dog walk. You can bring it, put it down below your nose if nobody's around, but wear the mask. Don't just walk around when you're walking your dog without a mask on. It doesn't say very much to other people that you don't care about protecting them. Practice social distancing. Weigh your risks. Today I'm going to go to Trader Joe's. Tomorrow I'm not going to, do this. You have to kind of pick your high risk things and be prepared to do them. Wear a mask when you're going to go shopping, or if you're going to go out where there's going to be other people. The restaurant thing, outdoor restaurants that are truly outdoors where there's not a lot of crowding together are safer than an indoor restaurant for sure. They're not as safe as eating at home. So that's something you really have to think about. Stay informed, follow the science, be creative, come up with other ways of engaging people that are satisfying but safe, be thoughtful, and be patient, because we don't have a choice. We got to get through this, and we can. And I don't know if I showed this on the first go around, but this is my grandmother's group of friends in the 1918 pandemic in San Francisco. And even then, they recognized that wearing a mask was really important. So now I'm happy to take questions.
Wonderful. With that, I'm going to stop the share there. Perfect. Bring it back to us. So again, thank you, Dr. Kimberly Shriner, for going through that information. I know we had some issues with LinkedIn Live when we were starting, but we are online with Dr. Kimberly Shriner. She is a infectious disease and tropical medicine specialist from Huntington Hospital and also the director of the Phil Simon Clinic. So we are going to open it up for some Q&A now. We did have a number of questions from our audience here. Do we know why some people have no symptoms while others have serious symptoms, and what causes this difference? Could it be as simple as a strong immune system?
It could be. We don't really understand that. There probably are some genetic things that are happening that we don't understand. That being said, asymptomatic people can still be very effective spreaders, so they may actually have a lot of virus. Why they don't get sick maybe is a function of their immune system, maybe some genetics about their immune system, or just how the virus, the dynamics of the virus in that particular individual. But that's been a really scary thing with this virus, is we don't really know who has it, and those people may be the ones who are the most likely to spread the disease.
Thank you. And then we did talk a little bit right as you were closing about the safest way to be outside with others, if it's a picnic or a restaurant and you're not wearing a mask, what are best practices? Maybe, well, I don't know if you can speak to that.
Lots of people, keeping the groups small. This is not the Thanksgiving to have your elderly relatives because, they have very bad outcomes. So, it's really important that we protect our vulnerable populations. If you're going to have a Thanksgiving gathering, less than 6 or 8 people, well distanced apart. If you can have it outside, we're lucky we live in Southern California. Most of the time it's nice weather. If you can do an afternoon Thanksgiving and do it outside, that's the best way to do it. Indoors, really risk goes up. And because when you take your mask off to eat, that's a potential transmission time. And people get, you have a little bit of wine and you get a little loopy, and then their barriers begin to drop, and that's when transmission occurs. And over again, we see these family gatherings as high transmission events, birthday parties, bar mitzvahs, Father's Day, Mother's Day, that kind of stuff. It's a normal thing to want to be with your family, but the best way to protect your family is to just get through this next couple of months, and we get on the other side of this. Again, you can have a big Thanksgiving in June or July when we're hopefully on the other side.
You talked a little bit about the testing rates and the false positive and false negative rates, what that looked like. Do you think that's going to improve as we go through time, or are you seeing an improvement there?
We're seeing an improvement. I think that's going to be a very big part of getting back to normal, whatever the new normal is. So for example, we're working very quickly on fast, easy tests with saliva that are accurate. Somebody spits into a cup, 10 minutes later, you've got a very accurate test. Do they have COVID or not? That's how we get people to fly again. You go to the airport, while you're doing your, check-in, taking your shoes off, you spit into a cup, they run the test, you've got COVID, you're not getting on the airplane. You don't have COVID, you get on the airplane. Same thing for schools. We are doing that a little bit now in nursing facilities where staff are getting tested before they go in. The tests we have available right now are not that accurate, and they miss a lot of people. So that's why they're still kind of dangerous. But the Yale saliva test, I mentioned that in that slide, that's a pretty accurate one. And there are a lot of companies now that are creating very highly accurate PCRs that can be done very quickly, that we can get those kind of results. So that's going to be a huge help in terms of bringing people together safely.
That will. What are the risks we can see from mutations, and how will this affect how we treat COVID-19?
The mutation thing has been more a reflection of its infectiousness. As I mentioned, this 614 mutation, the Wuhan variety was infectious enough. The Italian variety was super infectious, and that's the one that's really become the dominant global form. Whether this virus will mutate and become resistant to whatever therapies we might have is a concern, and certainly as we try to develop therapies for this virus, that's going to be a consideration. I didn't mention the fact that, if the vaccines don't work, or the vaccines are very problematic, the other way out of this problem is to use therapies. We do that with HIV. We don't have a vaccine for HIV. but we have very, very good therapies. And that's controlled the pandemic. You put people on medications, they're not viremic anymore, they're not infectious. You treat people prophylactically, either people at high risk of acquiring the disease or post-exposure prophylaxis after they've encountered the disease. And I just don't see, there's not a lot of money being put into that because all the funds are being pumped into vaccine development. And so it's a little bit scary in terms of, also as a clinician, you want to be able to do something for your patient. It's pretty humbling to watch somebody dying from this disease and you really don't have anything to offer them. And I've been it's been a little bit disturbing, sort of the lack of energy put into developing therapeutics. And when we have the ability to do it, we know how to treat HIV, a very complicated virus. And I'm hoping that some of these companies like Gilead Sciences and so forth are looking at this as well. They make remdesivir, but remdesivir has really been kind of a meh drug. It just hasn't worked very well.
With the false positives and negatives, how is that affecting the count of COVID cases?
The testing doesn't affect the number of COVID cases. Testing detects people with COVID. Does it miss some people that have COVID so you get a false negative test? Yes. Does it maybe pick up somebody who maybe doesn't have COVID that has a false positive test? That's less common if you're using good tests that are like PCR-based tests, which is what the county tends to use mostly. As we start utilizing these point of care tests, the Abbott test is sort of the first one. They now have another generation one that's much better. The first one has not been very good. Those rates will improve, but testing doesn't influence the pandemic. It just detects who you've got and who's positive. And I think that's a really bit of misinformation that's been very dangerous, that, well, of course you're going to have more cases because you're picking them up. But that doesn't mean that those cases are out there. That means that's the disease that's out there. You're just identifying it. So the testing thing is, yes, it dictates a little bit in some of the accurate, certainly if they're not accurate, it may influence what the statistics that you get. And you want to pick tests that are going to detect the disease. So it is a factor, but it influences the amount of disease.
Okay, so more around the statistic piece. And, do you think there's a focus right now on, how to take those false positives and negatives and incorporate that into the statistics?
Yeah, when you're doing large volume testing, then those kind of the false positive, false negative rates are smaller. That's why you can use less accurate tests if you're testing more people.
Okay.
And so there are some statistical things that happen, but that doesn't, we know there's look at the hospitalizations. That's the disease. We know those people have COVID. We know that as deaths and people having to be hospitalized go up, that means there's lots of disease circulating in your community. And so even if you didn't have testing, say, we've got a lot of COVID in our community because the whole ICU is filled with them. So.
Exactly. And last time we talked a little bit about the innovation that you have been seeing through this process. You talked about the doctors being able to stand outside of the room, but still monitor what's going on in the room. Have you seen anything else like that as we've gone through this process?
Yeah, I think one of the things that's going to happen, Huntington we're working on establishing a permanent sort of pandemic ward. We need to be alert. We're going to be dealing with this pandemic for several years, hopefully not on the same level as we have it right now. But, there's always going to be outbreaks. And so we need, and there may be something else that comes along, and it may happen at the same time. I mean, as we destroy the environment, as we have more encounters with viruses that we've never seen before, that our species has never seen before, this is going to happen again. The HIV pandemic was a zoonotic spillover. This pandemic was a zoonotic spillover. Ebola is a zoonotic spillover. Snake bites are on the rise because their environments are being destroyed and they're coming in and encountering people. I just saw a big giant coyote walking down my street yesterday. As we converge on wild areas, that's why this is tied into conservation and climatology and so forth. This is something we have to be prepared for. And this is a really hard lesson at what happens when something gets away from you so quickly.
Yes. And then on the kind of the technical medical, back to that for a second, what causes the blood clotting is one of the questions.
So the coagulation system is very entwined with the inflammatory system. And the inflammatory system, our immune systems are enormously complicated. We've learned a lot about the immune system thanks to HIV in large part, but our understanding is very, very superficial. And the coagulation system is a very primitive part of the immune system. And so what happens is as you develop all these chemicals that are secreted during the response to COVID, and many of the chemicals become inappropriate, these molecules that are inflammatory molecules, they signal the coagulation system to start forming clots. And then those little clots go all over the place. They go to your brain, they go to your heart, they go into your arteries, they go to your abdominal vasculature, and they cause death of tissue. One of my patients that I had back in April had a big clot that went to her hand, and her hand became gangrene. And it's a very impressive, and it's kind of unique to this virus. Because it causes this really weird, just chaos in the immune system. HIV suppresses the immune system, so people get these weird infections that they wouldn't get if they had a normal immune system. SARS-CoV-2 activates the immune system, but in an inappropriate way. So it just kind of goes haywire, and then you have all these bad events.
I know that we need to wrap up in a few minutes. I wanted to open it up to you if there is anything, that the questions have brought up or anything else that you would like to leave us with before we wrap up with you.
Well, I think, information is the most powerful tool that we have, and science is the conduit to that. And so it's very important that we do good science, that we support science and facts. And, during pandemics, what's happened with the political environment and with some of the misinformation and with people that are not experts that are making decisions about things, that happens during every pandemic. That happened during the HIV pandemic. It happened during the 1918 pandemic, where it's because people are afraid, they follow something that makes them feel better. This is really hard. This is a very, very scary thing. I'm an infectious disease doctor. I've been practicing for 30 years. I've seen a lot of infectious diseases. This is a very, very scary one. And it's not going to be our last one. And so it's important that you take a step back, that you pull together. We do much better when we're together, not when we're divided. And to support science and listen to people that are calm, that give you the right information. And then we can make the right decision. And sometimes it's very easy stuff. Wearing a mask is a super easy thing to do. It doesn't hurt you. It protects you. It protects the people that you care about. And so paying attention to that is how we get out of this. However, the fancy medications and fancy vaccines and all the things we can do in hospitals, those are important. But the most important thing is to pull together and think together. This is a challenge for the whole planet. I was looking at the moon the other day when I was out on a walk. And I was thinking, if you were on the moon and you were looking back at the Earth right now, this thing is circulating around the Earth. Everybody on this planet is affected by it. That should be a unifying thing, not a dividing thing. If we can invent the cell phone, if we can drive a car on Mars, we can do this. We can get over this pandemic, but we have to do it together.
Great. Thank you for those inspiring words, Dr. Shriner. We are going to be moving on to open networking here in a second. I also want to just let you know we are going to be going on a break for Friday Coffee Meetup, but we will be back in January with Nick Stein, who's going to lead us in meditation, who's kicked us off the last 4 years. So for those of you that are interested in continuing open networking, stay on the line here on the Zoom. I'm going to shut off the live streaming on LinkedIn and shut off the recording, and then we will move you over. Again, we are so grateful, Dr. Shriner. Thank you for your work, and we look forward to possibly hearing from you again in the future as hopefully things get better and we can follow your guidance.
Sure, anytime.
Thank you.
Thank you, Christy.
Okay.
Bye.
Okay, thanks all.